A very good morning to all of you. It's such a great pleasure to see all of you here on a Sunday morning for this academic feast, and that too on a topic on breast imaging. But before I begin my talk for the day, first of all, I would like to thank Malad Medical Association for giving me this opportunity to present my work in front of all of you. I thank our chairpersons, Dr. Harshad and Dr. Tarla Jain, and especially the doctor who just sang that song before me. Doctor, your voice is very nice. So, my topic, keeping up with the current advances in breast imaging. Most of us are general practitioners here, and we are the ones whom the patients come and consult as the first point of contact. So why should we are not going to report, mammography or anything, but why am I here in front of all of you to educate you all on this topic? Because, my dear, the situation right now is so grave that according to this consensus, like the study which was done by Globocon 2020, in India itself, every 4 minutes, a woman is diagnosed with breast cancer. And every 8 minutes, out of those women, one woman, she dies because of breast cancer. So by the time I finish my 30 minutes of talk, you all can do your maths and you can see how many patients of ours would have been diagnosed with breast cancer and maybe would have been succumbed to death because of it. So that is why this is a very important topic for today, because many of our patients will be coming to you and you are the one who will be diagnosed and referring them and deciding the line of treatment henceforth. And what is more alarming these days is, in India, the women are being diagnosed with breast cancer at a much younger age as compared to rest of the world, almost a decade earlier. So we cannot think that, that if a young female is coming to us, so she will be only fibrocystic disease or a fibroadenoma. We have to think beyond. And for that, we need to update ourselves that what are the recent advances which are going on in breast imaging. Because our main aim is not only to detect the cancer, it is to detect it at an early stage. When we detect it at an early stage, we can maybe reverse this ratio in next decade and we can prevent the deaths because of it. So here is my role today. So when we refer our patients for any breast imaging or any other imaging for that sake, what we want for our patients is we want latest technology which is offering low radiation examinations for the patient. So mind you, that is the main thing which comes to the patients and doctors mind, that okay, nahi mammography में तो बहुत radiations है, तो आप मेरे patients को हम लोग नहीं करते, सिर्फ sonography करते हैं. What if there are investigations which have low radiations? We want better contrast resolution, because image अच्छी होगी तभी radiologist report कर पाएगा. And of course, accurate diagnosis. So what we know, our obvious choice is going for digital mammography. This we all know, right? But do we know that when we are referring our patients for digital mammography, is it CR, is it DR, it is FFDM, what is it? So this we can see, okay, the alignment is a little changed because of maybe the version of the word or the PPT. But then what we can see here is that when we compare CR, okay, that is the computed radiography, which has been there in almost entire western suburb belt, which at VCare we also used to practice, say around 3 years back. So this is only advantage for CR is it is very less expensive, it comes in around lakhs, that machine, and it is compatible with our current X-ray machine. We just have to buy the normal mammo machine, and we can give our prints on normal X-ray machine printer also. But what about DDR or DR or FFDM? This is what is the latest thing which we are talking about right now. Everything is good about it. The only disadvantage is the expense. So the expense is so different that this one which is coming in around lakhs CR, this is in crores. But what is the advantage? Then why should we spend so much on our imaging? Because multiple studies have been carried out, and this is the consensus from one of the study which was carried out in Toronto, Canada. That CR was 21% less effective than DR. 21%. Is it a small number? When we are suggesting our patients to get a digital mammography done, can we afford our 21% patients to come with a wrong diagnosis just because of, say, difference of 500 rupees or something? Is it worth it? Are we educated enough? So that is why we should be aware when we are suggesting digital mammography, is it a DR? Is it FFDM? So these are few of the specifications of that FFDM, but I will not go into the details. This is how it helps us with a low radiation, better contrast resolution. But yeah, this slide I would wait a little. Because another concern for the patients is कि डॉक्टर साहब पेन बहुत होता है मैमोग्राफी में. मुझे मैमोग्राफी इसके लिए मैंने किया था 4 साल पहले, इतना पेन हुआ, मुझे दोबारा नहीं करना है. So what if there is something which is actually taking care of that pain also? Yes, it is there. This machine, what we have come to know is, so on the left side, I am showing you a routine machine. So this ball is representing patient's breast. Patient is standing over here. Okay, so this is the chest wall. So what happens when the paddle is coming to compress the breast? In a normal case, it will come horizontally, so it will press the front part also, and it will pinch the chest wall also. Whereas in the new machine, what is happening is, you can see it is tilted. We don't want to press the chest wall. We don't want to cause pain to the patient. What we want is adequate compression of the breast for our diagnosis. And is that our purpose served? Yes, without causing pain to the patient. But if your patients are already having mastalgia, if they are already having any kind of pain, so they already have pain. But if they need mammo, they need mammo. So that time, even if you touch, you do clinical palpation also, the breast is tender, it's going to cause pain. So mammography is not causing that pain. Even sonography will cause pain, or maybe touching the palpation will also cause pain. But patient will only feel some pressure. Then viewing. Okay, I have taken very good images. How do I view my mammo images for diagnosis? Can I take my mammo images and look at my X-ray film or mammo film like this and diagnose microcalcifications? No, probably not. This is not the way. How about that, just the normal viewing station? We, as a radiologist, we have got working stations. Normally megapixels are around, screen megapixel is 0.2, maybe 0.5 also. But mammography, we need much higher resolution. So we have got these monitors, like the megapixel of these monitor is 5 megapixel dual monitor just for mammography. So when I'm studying it, I close lights in my room, and this is what we are focusing. So there is a specific technique, and that is why we are doing all of these things. क्या हम लोग नॉर्मल स्पेक्युलेटेड मास या फिर एक ब्रेस्ट कैंसर डिटेक्ट नहीं कर सकते? कर सकते हैं, बट दिस इज नॉट आवर पर्पस. आवर पर्पस हियर इज टू डायग्नोस इट when it is an early stage, when it is at DCIS. Okay. So now we all know that अगर speculated mass मिल गया, then the management is MRM. Okay. We will remove the breast, but that is not giving that kind of quality of life to the patients. Apart from detecting early, we want to give a good quality of life to our patients post the treatment also. So breast cancer is treatable in that case, right? And with a good quality of life. So, for example, I'll show you some cases. Now this 49 years old female, she noticed a lump in the right breast 1 month back, okay? Although she noticed it 1 month back, we can see nicely, we all can see this nice speculated mass in the upper outer quadrant of the right breast, okay? But what is important for the oncosurgeon is this speculated mass, anybody can say, we all can know, okay, we can see that, okay, this mass is there. But Now whether the oncosurgeon, he should go directly for MRM, or is it something we can do better for the patient? Yes, we can go for breast conservative treatment. We can just remove that lump. But is it possible? We need to give other details to the patient doctor, that we need to tell whether there are satellite lesions which are present there. So what is the actual extent of the disease? So here we see that this is the mass, but what about these? The cancer is already spread over here till here. So these are the satellite masses. So the extent of the disease, now it has changed. Now the oncosurgeon can decide the treatment, that whether he will remove this large portion or whether the MRM is required still in this patient. Otherwise, what if he would have done just the BCT only for this cancer, right? So we did sonography also. We found these speculated masses and satellite masses. We also saw some ductal extension. It was going towards the nipple. And so we gave it as BIRADS 5, that is definitely malignant. And on biopsy, this was confirmed to be infiltrating ductal carcinoma grade 2 with ER positive, PR negative, HER2 positive, and the Ki67 index was 28%. So this was another 45-year-old female. She presented with painless lump in the left breast since 15 months. So here again we saw these masses were there. This was a satellite mass. We took this spot magnification views. Yes, so because of the quality we cannot see here the images very well, because I am not in my dark room. This is not my 5 megapixel monitors, but then yes, still I can see some micro calcification. Excuse me, can you please lower the volume please? Yeah. So I can see these grouped micro calcifications which are extending much beyond the masses. So this is very important again here, that okay, that we know that these are the masses which are present here, but these micro calcifications are spreading much beyond. So this is how we come to know the disease extent. Whereas on the sono, hardly this heterogeneous mass was seen. We already also saw an involved lymph node. Again, the biopsy was done and it was proven to be infiltrating ductal carcinoma grade 3 type with ER-PR positive, HER2 negative, and Ki67 was 28%. So what is all this? Maybe like many of you might be knowing about this ER-PR positive and HER2 negative, but I would just say one line for those who might not be aware about it, that I am seeing lot of patients, doctors who are prescribing FNAC for their patients. Okay, we know that this is a mass, we are suspecting a mass, and we are suggesting FNAC. So will FNAC tell us that what is the type of tumor it is? No. FNAC can at the max, it will tell you that okay, there are no malignant cell seen, or it might say that malignant cells were seen. But what is the type of tumor? Unless we know, like is it a ductal carcinoma, is it a lobular carcinoma, is it a triple negative cancer? So accordingly, my line of management will change completely. So that, how do we come to know? Is it biopsy? So please, at the end of this lecture, I want all of us to at least take this one point home, that you know that if it is a solid mass, please refer your patients for biopsies. Ideally guided biopsies. If the lump is very clearly visible and everything, we can go, the surgeon can take a direct biopsy also. But FNAC, I suggest only for the cysts. So where aspiration is done for the fluid, and we send that fluid for cytology. And then, in fact, in those cases also, if you are having any doubts, what we do is the biopsy of the remaining cyst wall also. Now the patients, we all know that the patients, if the patient is presenting with lump, hard lump, it has to, you know, it could be a cancer. But what are the other things? Like bloody nipple discharge, spontaneous unilateral bloody nipple discharge, or the patients may even present with a retraction nipple. Okay, like in this case, she presented with a right side retracted nipple, but we could not see very clearly. We took a spot magnification views and we could nicely see this speculated mass. On sonography also this lesion was seen, but not so good. But then a few satellite lesions were also picked up. We did a sono-guided biopsy, and what we found was an invasive lobular carcinoma. So this is what I want to stress here, that invasive lobular carcinoma, they are not the typical usual presentations like a ductal carcinomas. the ductal carcinomas those patients will come to you usually in a late stage with a nipple retraction and all those things. But lobular carcinomas, the patient might be completely asymptomatic most of the time, and the patient might just, sometimes give a vague history that my right breast or maybe left breast is becoming smaller as compared to the opposite side. No mass is felt, nothing. So what do we do? Do we just counsel the patient and go home कि नहीं नहीं आप breast में asymmetry होती है? No, we have to get it investigated, definitely done, because lobular carcinomas, that is the reason they present very late, but if they are picked up well in time, the prognosis is good. Then how about young females? As I told you that, it's already almost a decade earlier, the cases are being noticed in India. So this was a 27-year-old female. She presented with a hard, painful lump in the left breast since 8 months. So this lady, she came to me in my OPD around 8 o'clock in the night, and she was getting married 1 month later. She said, "Madam, I want to get a sonography done." Fair enough. I did the sonography. Clinically, I was feeling such a large lump was there, but on sonography, I was hardly seeing any lump. I was not just some acoustic shadowing was seen. So I convinced her that, "No, madam, let us do your mammography." Fortunately, that patient listened to me also, and the same time we did mammography for that patient. What we found was almost the entire left breast was involved. And you can see on spot magnification view, you can see a speculated mass here, and there is already something has started happening under the nipple also, and the nipple is slightly retracted as well, which was not clinically very apprehensive, appreciable, because the right nipple was also slightly like that. But then it was seen on mammo, and we did biopsy. It came out to be a triple negative breast cancer. So triple negative breast cancers are the most dangerous ones. First of all, they happen in young females. Secondly, they are triple negative. So we cannot give any hormone therapy to them. What we need to give is neoadjuvant chemotherapy, which this patient is on currently. And let us see how she does face the prognosis after it, chemotherapy. Now this was a 59-year-old female presented with just a dimpling of the skin. Okay, so this also dimpling. So nipple and everything is felt, no mass is seen clinically. Just she said, a small dimpling is felt, that was just parasternal on the left side. So you can see here, when I did mammo, I could just see some little dimpling of the skin retraction. On spot magnification views, however, I could find a small speculated mass. I did sonography biopsy for that. Now this one is a very tricky one. So you can see this mass is just approaching just above the chest wall, and here was the heart. So if my biopsy gun would have gone anything, just maybe a little here and there, we could have been facing some severe consequences. So that is why image guided biopsies are very safe, because we know where our gun is going. And this was detected fairly early. The Ki-67 index was 11%. So above 18% is when we say, that it's very aggressive tumors. So this was ER/PR positive, HER2 negative, infiltrating ductal carcinoma. This is another very interesting case. This was an upper middle class lady, I can say higher class lady also. She presented to me with a huge left breast. The left breast was almost coming to the right side, and she was like this since almost 2 years. So we always have the mentality that usually village people, they ignore their cases and all, but no. Now this lady, she had a huge breast. When I tried to do the sonography, the image was not fitting in one screen. The lesion was around 15 centimeter. Okay, that too, like I might be, underestimating it a little. So when I probed her a little, so I came to know she was hit by a cricket ball 2 years back. And for 1.5 years, she did not do anything. For 6 months back, a surgeon had put a pigtail catheter, the drainage was done, and after that, this is the situation, current situation. You can see this is an organized hematoma. And I talked to that lady after my investigations also. I called up the surgeon as well. The surgeon also, still that lady, she's not doing any treatment. That lady says, I am doing positive affirmations. I'm doing Reiki therapy. I'm going to heal myself up. So why I brought up this case over here is because this is where our, that clinical scenario comes into place. That this is how we have to spread the awareness to our patients. Now, not only in the lower class or maybe socio-economically or maybe a higher or upper middle class, in all some kind of the other, backsets are there. So we as a doctors, we have to take this initiative. Now this is a 47-year-old female. She presented with a lump in the right breast which she noticed few days ago. We can nicely see this speculated mass. We can also see satellite masses here. On spot magnification view also, we can see some pleomorphic grouped calcification which is even extending beyond. It's not very well seen on the screen here, but then yes, it is there. Trust me, it is there. I will not lie. So this is a satellite mass here. And this is on sonography, this is how the mass appeared. So this was definitely a ductal carcinoma, infiltrating ductal carcinoma. But what I want to point out here in this case is, unfortunately, this patient had done a mammogram outside on a CR machine in 2020, where this lesion was already started, okay? And this is how you can see at the same site. We can at least see this focal asymmetry, and there is also some pleomorphic microcalcifications here. It is there. And so if at that time, maybe if it was there, so these are the images are not so good because I have taken these images from the view box. I have clicked it from my camera. But then if it would have been in the hands of a good breast radiologist who would have diagnosed it, so this patient right now would not have presented just in a span of 2 years with this large speculated mass with satellite masses. And her quality of life we could have given her at that time would have been much better than the management which we are giving her now. With this, I would like to go to my next topic, that is MRI of the breast. MRI of the breast. It's a state-of-the-art imaging modality. I just love this imaging modality. I do love my digital mammography also, DR, but then MRI breast is something, it's my passion. Why? It has got the highest sensitivity, because when I told you I want to detect my cases at the earliest so I can give a better life to my patients. So this is where MRI breast helps me. It gives an excellent discrimination between benign and malignant lesions. And the indications of MRI, they are expanding. I will go through it. That when do you refer your patients for MRI? So what is the basic principle? I will not spend too much time here. Spend 1 or 2 lines here. That as opposed to mammo and sono, contrast enhanced MRI is a functional technique. Okay? Because what we are doing in mammo and sono, we are seeing the lesion. In MRI, we are doing contrast, and it is a functional technique. How is it a functional technique? Because when in any malignancy, that we all know what basic concept is neoangiogenesis. Okay? What is neoangiogenesis? The new vessels are being formed. They are they're forming very fast. So there is formation of leaky vessels. So those leaky vessels, when we give an IV contrast, they allow faster extravasation of the contrast, and there is rapid local enhancement. So what happens is, because that lesion is, the malignancy is very vascular, because there is neoangiogenesis, the contrast goes in also very quickly, and it comes out also very quickly. So what we do, we use a little statistics, and we graph them against this, plot them against this graph, and we get these curves. Okay, they help us to certain extent. That these are type 1, 2, 3 curves, but the most malignant here is, as we can understand, the one which goes very fast and the one which washes out also very fast. So those are the kind of lesions which we put more concern into. But that is not the only criteria. There are other criteria also for breast MRI, but this is the basic funda. What are the requirements of breast MRI? It should be interpreted by an expert in breast imaging, not only MRI. It should be mammo and ultrasound studies also, because many of our patients How much time do I have, doctor? 5 minutes. Okay, I'll just try to wind it up soon. So, and we need a dedicated breast coil. So these are the certain indications. I'll be going through them one by one. So this was a 50-year-old female. She presented with a hard right breast with a skin thickening. So we can see a large area of involvement. We could hardly see anything on sonography because, this is the area of involvement, but there is no delineated mass or speculated mass or anything. Sono, I was completely inconclusive in this case. I did a MRI. So what I saw here was almost entire right breast is involved here, okay? And also along with that, there is some skin thickening which is present. And we also saw some lymph nodes. We gave a differential of malignancy and granulomatous mastitis. Granulomatous mastitis can very well mimic even on imaging with the malignancy. And fortunately for this patient, it came out to be granulomatous mastitis on frozen section, and the patient has been treating accordingly. Now this case again, this is a very nice case for us to study the importance of MRI of the patients. So this lady, she had come from village. She had done multiple surgeries of the right breast because she had a delivery 5 years back, multiple INDs were done. Then again, what happened that this portion, medial to the nipple, here she was complaining of some pus discharge right now. And she was just fed up. She had got some surgery done in the village. The operative notes were not available. Query, it was written subareolar excision, which I think could be a lumpectomy. But what is happening here is clinically you can see the breast for a 26-year-old female. This portion of the breast is almost gone completely. And right now she is presenting, and she was so fed up. She had come from a village. She said, I can't stay for this long with my relatives. Doctor, please remove this portion where the nipple is discharging right now. Okay. I did sono. So this is the sinus tract. It is lined with granulation tissue. This is the nipple area. But I suggested MRI. Okay. And fortunately, that patient got it done also for me and for the breast surgeon. What happened, what we found, that this was not the only area, that sinus tract. The entire right breast was involved. So what would have happened if the surgeon would have succumbed to the pressure by the patient and the surgeon would have just removed this medial aspect? What would have happened? This portion would have again left and patient would have said कि Mumbai में भी doctors अच्छे नहीं हैं. Patient was already like this. So what would have that is why this patient was then counseled again. Now patient is on, and this patient was diagnosed with granulomatous mastitis. And so patient is on conservative treatment right now and no surgery is being done right now for her. And we will follow her up after the conservative treatment. Now this was a 54-year-old female. She came for routine screening. So we can nicely see these linear microcalcification in a ductal orientation. So only this part is seen. It was very well picked up on spot magnification view. But when we did MRI, we saw such a big area was involved. So then that change of management. So this is a case of DCIS. So the MRI indications is it is much more superior for the tumor size and finding the additional foci. Now this is another nice case in the ductal pathologies, as I already showed you, for DCIS. MRI, in this case also like in mammo, we saw focal asymmetry in the upper outer quadrant of the left breast. On sono, we could find this focal ductal ectasia with echogenic contents, vascular. But when we did MRI, again we saw it was a big area of DCIS involvement. And this was a typical DCIS. So again, the management changes. So whenever it is indicated, we must get, especially for the ductal pathology and for screening of our BRCA1, BRCA2 positive patients also. Even in post-neoadjuvant chemotherapy, like in this case, so this is pre-chemotherapy and this is post-chemotherapy, we can see, we can monitor with our MRI how is the response to neoadjuvant chemotherapy. Is it a complete response like this or is it a partial response like this? So post-neoadjuvant chemotherapy and in breast implants. So this was a patient who had done breast implants say around 15 years back in Bangkok. She wanted to remove her implants now. The surgeon said, go get an investigation done. I want to see whether anything is going on before it. I did a sono. Hardly I could see the entire breast. But when I did MRI, I could nicely see the entire implants and I could detect any cancers which were there, which were not there for these patients. So, screening and monitoring of breast implants. So I'm going to wind up here. So this is, I would just show you, take you through a few glimpses of our diagnostic center, WeCare. So this is our waiting area. This is our mammo machine. The left side, this is our CT room, our MRI room. And this is how the patient has to lie down prone on the MRI machine. And with the breasts are in these cups of this breast coil. And I thank you all from our, especially I'm thankful to my breast team, without whose support, I would not have done all these wonderful cases and helped all these patients. And I thank all of you for being so kind and so patient and being so enthusiastic to listen through all of this. Thank you so much.
Thank you, Dr. Namrata, for such an excellent talk.
Thank you,
It
sir.
was indeed a very wonderful session to begin with our MALCON. I now request our chairperson, Dr. Harshad Joshi sir and Dr. Tarla Jain, to please felicitate our speaker, Dr. Namrata.
Thank you, sir. Sir, any questions from the audience? Can we take some questions?
I think questions we'll take at the end or maybe in the lunch session because
Okay,
we're a little short of time.
sure.
Madam.
Thank you, thank you.
Thank you.